Welcome to the AO North America Trauma Hand series. We are going to discuss Fireside chat on distal radius malunion. The faculties and moderators are as follows. My name is Emil Dionysian. I'm a associate professor at Southern California and at Kaiser Permanente. We'll have our faculty, Marco Rizzo, professor at Mayo Clinic, and of course, Jesse Jupiter, our sage, who's famous enough, doesn't need any introduction, but he's from Harvard Medical School and currently resides part-time in Florida. These are our disclosures. Dr. Rizzo and I have nothing to disclose, and Dr. Jupiter's disclosure as follows here. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of the patients and musculoskeletal injuries. We don't endorse any product or promote any services. Equipment used in this presentation are solely for demonstration and teaching purposes. So our agenda for today is I will present a case with the evaluation management and going over briefly about the malunion treatment for distal radius. And then Dr. Jupiter will bring out his experience, over 40 to 45 years of experience of how to do it and the lessons that he's learned over the years. And then Dr. Rizzo will present a complication case and how to navigate that. And then we'll have some time for discussion with question and answer session, and we'll adjourn about a quarter after the hour. Now, learning objectives for this session is to identify radiographic indications for surgical procedures of distal radius malunion corrective osteotomy, identify and understand the clinical criteria for this surgery, define the appropriate and surgical anatomy needed for this surgical steps, recognize the possible pitfalls and the possible complication, and have a brief understanding of the literature about this problem. We've had already several of the sessions of the Fireside chats, one remaining after this one. It's in December 14. I'm going to put a plug for that. That's going to be about the distal radial joint arthritis treatment with Dr. Amit Gupta as our sage. Now, upcoming webinars in 2024, we have a great set of webinars set up. We will still have another webinar coming in terms of AO hand for a terrible triad remaining this year in December 6th. And there were series, as you see, on acute fracture of the scaphoid, skin flaps, finger flaps, both bone forearm fracture, and distal radius malunion next year in 2024. Remember, these lecture series are all recorded and can be watched on YouTube under AO Hand North America. And also encourage you to sign up on the Ortho TV and Ortho TV online for live streaming and watching further such videos. Now, just briefly go over the distal radius corrective osteotomy. Distal radius malunion is a common problem. Generally, distal radius fractures are about 15 to 17% of all fractures that happen. Malunion is not unusual. About 11% of them, even more perhaps, depending how you define it, there's a complications as a malunion. Not all malunions are symptomatic. Not all need treatment. But if there is a significant limitation with activity causing pain, especially ulnar-sided pain because of the shortening of the radius, then some kind of a corrective osteotomy may be indicated. Now, malunions could be several types. It could be extra-articular, which is the most common. Then it could be intra-articular, or it can be combined. And remember, malunion can happen in multiple planes. It could be with the volar tilt, angulation. It could be radial inclination problems. It could be radial height change and shortening, and also could be a rotational deformity. And frequently, there's all 3 or 4 concepts are involved here. Now, what happens with this malunion of distal radius? The change in the distal radial ulnar joint will cause problem with the smooth gliding and function of that joint. Once we have the joint tilted, the carpal malunion will be another problem, or sorry, malalignment. Shortening of the skeleton will cause extrinsic muscle weakness because of the lengthening relatively, and then there's going to be a mismatch between the extrinsic muscle and the intrinsic muscles, and they all result in weakness. Now, indications for osteotomy are not absolute. They're all relatives. There are always possibility of complications. So when discussing with the patient, we have to look at the whole patient and look at what we can do and what is possible. Now, generally in the literature, most of the indications go in the realm of dorsal tilt of more than 15 degrees, or the radial inclination is less than 15 degrees, or if the shortening of the ulnar variants have shortened more than 3 to 5 millimeters, or it's a clear ulnar carpal impaction, or it's an intra-articular displacement of more than 2 millimeters, which tend to lead to arthritis. Those are maybe relative indications for doing a distal radius corrective osteotomy. Now, how does the mechanics work in there? Once we have discussed, we have the shortening of the radius, there's going to be a grip weakness because the relatively muscles are looser and lengthened. Whereas there's a dorsal angulation, there's the distal radial ulnar joint incongruity that will cause problem with the pronation and supination. As a result of the tilt change, there's going to be a dorsal, especially dorsal tilt, there's a dorsal-radial subluxation of the carpus, which can then result in the adaptive deformity of the carpal alignment, especially a dorsal intercalated segmental instability, or DC. And excessive tilt, depending on which way, if it's a dorsal tilt, will cause decreased flexion and supination. If it's a volar tilt extension, then it's a decreased extension and pronation. Of course, the forces change. If the radius shortened, the ulnar carpal forces increase, and the estimated, just 2 or 2.5 millimeter shortening of the radius would increase the pressure on the ulnar by about 40%. Now, how do we image for this problem? Definitely, we want to get a contralateral X-ray to know what is the normal or theoretical normal level of the original alignment, so that we know how much we have to be corrected. Especially getting that 25 degrees elevated lateral will allow us to see an intra-articular segment to see if there's significant step up. CT scans can be helpful, especially a 3D image, so that we can know what are we dealing with, where is the maximum area of the deformity, and also consider MRI if there's worry about the ligamentous problem. Now, as far as surgical planning, this concept of dorsal approach initially became popular with Diego Fernandez's article in 1982. At that time, we didn't have locking screws, so the idea was to have a corticocancellous graft dorsally, because most of the problems were dorsal malunions, to correct it and put a corticocancellous graft and a dorsal plate. After advent of the locking screws and the volar plating becoming popular, then a volar approach started to become popular. Since 2008, most of the articles about doing volar plate approach and volar osteotomy. Of course, sometimes we may do a ulnar shortening osteotomy if we cannot lengthen the radius enough or there's too much discrepancy. Sometimes we may do both radius and ulnar. And so question comes what to do with the ulnar styloid. Sometimes the ulnar styloid is a large fragment, which is painful and has a non-union that may consider doing surgery for that, especially if there's instability of the distal radial ulnar joint. And also have to worry about the triangular cartilage. If there's any injury or a tear, we might want to repair at the same time we're doing the osteotomy correction. The surgical plan, it's important to know where the maximum or where the location of deformity is, because you want to do the osteotomy at the location of deformity. If you do the osteotomy somewhere else, then you may develop what's called a Z deformity, or to cause translations, which is may become problematic. And also have to remember there's always maybe a rotational deformity that we might want to correct at the same time of the osteotomy. And also think about the different planes, the coronal correction and the sagittal correction. Most fractures have component of coronal and sagittal malunion in the deformity. As far as the surgical plans, generally an opening wedge osteotomy allows to lengthen the skeleton. And of course, that would cause a gap. And then the question comes whether we should have a bone graft or not. And there are different studies that shows that different kind of bone grafts can be helpful, or sometimes even no bone graft as long as there's a cortical abutment. And then this concept of closing wedge osteotomy, which allows a quicker healing of the bone, but it does shorten the skeleton somewhat. And also question is how to reduce it. Sometimes we may use a distractor dorsally, or use the plate itself as a jack and to correct the malunion using the plate as in the lower picture. When it comes to complex correction, sometimes a intraarticular visualization may be helpful. Sometimes there may be volar carpal subluxation that we may have to correct. Of course, every time you look volarly, you may disrupt the volar ligaments that may need to be repaired. Sometimes it's easier to dorsally look inside the joint. Saw cut is important to make sure you protect the surrounding tendons. It's very common to injure the extensor tendon, especially the extensor pollicis longus, which is very intimately attached to the bone dorsally. Be very cautious using an osteotome because it can easily cut tendons in the back. Three-dimensional guides have been very useful. Sometimes they can be 3D printed so that give you a better estimation of where to make the cut and how to do the correction. Now, as far as bone grafting, I'm sure Dr. Jubiter will talk more about this, but generally, first, when it was described by Diego Fernandez, 1982, dorsal bone grafts, corticocancellous bone graft was the standard. After a while, it was shown that with a locking system, we can even use a cancellous graft, and that would work okay. And then as late as 2014, there was articles coming out that as long as you have some cortical contact, you may not even need a bone graft. This may spontaneously fill in with time itself. So here's a case example as one of our 3 cases. This is a 62-year-old female. It was fell at home and developed this distal fracture. Of course, we tried to close reduction. It looks pretty decent. The radial height is relatively okay. The distal ulnar joint is well aligned. The dorsal tilt is about neutral. And of course, this went on to heal, but as happens frequently over time, when it heals, by the time it heals, it tends to settle. Now it's 1 year after. It's about almost 30 to 35 degrees of dorsal angulation and significant shortening. Has completely lost the radial height. It's pretty much 0 in terms of radial inclination. And the ulnar styloid is broken and is non-union and is tender. Now she has ulnar wrist pain. What to do now? Of course, we offered her osteotomy, and we did the osteotomy and also fixed the ulnar styloid. And that helped her. It wasn't a perfect, at the end of the all said and done, it wasn't all perfect, but she felt better. The ulnar wrist pain did resolve. She still has significant residual stiffness. In her case, we used a tricalcium phosphate bone filler and used a bone marrow aspirate to enhance the healing. Fortunately, we did not have any major complication and no tendon rupture or problems. She did have problem with the hardware, and we had to remove it later. So here's her after the removal of hardware. You can see The on the left was before the osteotomy, and then right after the osteotomy, we corrected the dorsal tilt and the radial height and the inclination. Now, these complications, Dr. Rizzo will bring up, you can have significant complications. There are some reports are up to 50% of complications. Most complications are tendon ruptures when you're doing an osteotomy from a scarred bed. You may inadvertently injure the tendons, or it may spontaneously rupture after the surgery because of the lack of blood supply or attritional. Plate fractures is not unheard of, or you may still have a persistent malunion despite all the efforts to correct it. You may still have a non-union. Of course, if you have some kind of a cortical contact, you will less of a chance for that happen. And also, there's a patient health factor. Usually, this kind of malunions and troubles happen in patients who already are sick. There are systemic problems. Could be some diabetes or neuropathy or severe osteoporosis. So those are factors to keep in mind. So take-home message from just this brief overview: not all malunions need osteotomy. Patient selections are important in this case. You have to think about multiple planes of deformity. Many possible complications are possible. Approach is important, and in general, less distractions and less correction, you get less complication. Okay, now how do we gonna do this? Fortunately, today we have the world famous Dr. Jupiter, who's gonna help us delineate the different steps to get out of trouble. So I'm gonna get my stop sharing, and Dr. Jupiter can continue with his presentation.
Thank you, Emil. Terrific overview. Let's see. Okay. And welcome, everyone. We've got quite a interesting topic, one that's becoming more prominent as people are interested in a better outcome from these injuries. You've seen my disclosures, so I won't go through that. What I'd like to look at is the following indications and timing and preoperative planning, and look at some of the operative tactics, address bone graft as mentioned, and look at some of the outcomes. What about indications? Well, more than anything else, it's a functional situation. Appearance, unfortunately, can occur, but functional limitations is preeminent, and pain is the biggest thing. Even though you may look at a modest malunion and wonder why the patient has pain, it can happen, and it's often from cartilage overload when the radiocarpal malalignment is sufficiently abnormal. As mentioned, midcarpal instability can be present by virtue of the deformity of the radius, as the radius is really the seat of the carpus. And you heard about DRUJ problems and obviously articular incongruity. Generally, advanced degenerative arthritis, radiocarpal, is probably not a good indication unless you're planning to do, for example, a radioscaphoid carpal fusion, and has a substantial deformity of the radius, so it might include an osteotomy to correct the overall alignment. Fixed carpal instabilities is important to recognize that if the patient's problem is motion, not so much pain, not so much deformity, and they have a fixed carpal instability, they probably won't gain motion if there's been an intercarpal ligament problem. So sometimes you need to sort that out. Decreased functional capabilities and extensive osteoporosis are obvious, but patients who have a good indication but have a very stiff hand or a non-compliant soft tissue, it's probably not best to do it right away. You always will see patients like this who come in for Dupuytren's or something else, and they've got an awful looking x-ray. You ask them, are you having any problems? No, never had problems in my life, stuff like that. There's something to be said about deformity, and that is we look at a three-dimensional problem in 2 dimensions when we look at x-rays. Furthermore, when we measure x-rays, we don't really appreciate that the true vector of deformity, it may be a combination of it. One of the great advantages of approaching distal radius malunions from a palmar approach is that you're able to pretty well correct rotation. Rotation isn't always visible to you looking at 2-dimensional x-rays, but the flat plate on the flat surface of the palmar aspect of the radius will generally correct most of the rotation, and that puts you in a better way of assessing the remaining deformity. And so remember that, because really all deformities, whether they're diaphyseal, metaphyseal, when we look at x-rays, we may not be seeing the true vector of the deformity, which may be a combination of these. We certainly have heard from Emil, and it's well known that if you lose the alignment of the radiocarpal joint, you may transfer load more inefficiently, either to the carpal bones or to the ulna. And when we sometimes look at an x-ray, if you look at an extension of 35 degrees, look at the way the lunate and capitate have adapted. And this is an adaptive malunion. And if you correct the deformity, it will correct the midcarpal problems. And these patients may come in with pain or clicking or other issues about weak grip, whatever, so that be careful about this, because the problem may be if you have a fixed carpal malalignment where there's been intercarpal ligament problems and you correct the malunion of the radius, you may not correct the carpal problems. And by shortening, it's a relative shortening, you increase the loading on the ulnar side. And this can be a big problem in promoting pain moving from the wrist to the distal radial ulnar joint. Years ago, we suggested that 2 millimeters step up. It was a very bad article, I have to tell you. If you read a subsequent article that we wrote in JBJS about a retraction, was a lot of the ways we measured was really in 1980s. We're not using CTs and whatever, but the observation was correct. And we know that positioning the end of the radius abnormally will lead to problems with the flexor tendons, weakened grip, and whatever. On the palmar side, a malunion is almost always associated with a supination contracture. Patients have a lot of trouble rotating by that. When to do this? Well, for years, we thought, well, we should allow the patient to rehabilitate the hand, which is appropriate, and then to get as much they could get out of therapy. And sometimes this dragged on and on when you're looking at a younger person with an obvious deformity. So if in the absence of trophic changes, acceptable bone quality and adequate wrist function, there's no reason to wait. And I started seeing this early on, and it made sense to me. And we looked at a series of 10 patients done early, that's within 5 to 8 weeks post-fracture, compared to the traditional way, 4 to 6 months, when it was well healed. And this is what the observations were. It was much easier to correct the alignment. You went right into the original fracture site, which sometimes is not quite obvious on the dorsal side, but very obvious on the volar side. And there was no need for structural bone graft And because you're doing it early, you certainly decrease the total disability time, and patients got back to work considerably earlier. What about planning? Well, you can see from deformities that it's a good idea to know what you're going to do beforehand. And Emil showed this original concept by Swiss Diego Fernandez, looking at it from the dorsal side and comparing it to normal side. You can determine to some degree what type of osteotomy you may need, whether it's you need to lengthen or not lengthen, by actually using the x-rays. Get a lateral and an AP x-ray of the normal and abnormal side. And if you superimpose the abnormal on the normal, and then draw a line connecting the volar aspect of the abnormal to the volar aspect of the normal, and then the very dorsal aspect of the abnormal to the very dorsal aspect of the normal, and then bisect those lines with perpendiculars. Where the perpendiculars interact will tell you about what type of osteotomy you need. So if you look at this on the top cartoon, look at the two lines intersect right at the volar side. That means that we will not need to distract the distal fragment, but rather hinge it on the volar cortex. But if you look at the volar cartoons, if you have a situation where the lines intersect within the substance of the abnormal bone, that tells you that it's mostly a rotational malunion. And it's almost a situation where you need to correct a little bit of the volar and add somewhat of the dorsal side. But a lot of this will be corrected by a volar plate. And then if the lines intersect far outside the two bones, then you know you will need to distract it. So, and this is the era of computer-generated preoperative planning, which is wonderful in its substance, but you can do a lot of this from x-rays. Having said that, we did a prospective randomized study looking at x-ray standard planning, like I've addressed, compared to 3D planning. These were for extra-articular malunions. It was published in the Journal of Bone and Joint Surgery. And patient-rated outcomes were slightly in favor of 3D assisted, but really not significant. So I would say, for me personally, the computer-generated planning may be better for intra-articular malunions. Here's one of the patients in this series with the computer planning. They will tell you where to put the plates, screws, etc., give you jigs to do this, and it's very sophisticated, and it's a little bit appealing. But listening to what Emil said and what myself, you can plan a lot of this preoperatively without this. If you look at extra-articular malunions, the goals are this. One is we want to reorient the articular surface to allow that normal load transmission, especially that where it's been translated to the ulnar side. We'd like to reestablish normal carpal kinematics and normal distal radial ulnar joint. Can you do this through a volar approach? Can you do this without sophisticated 3-op planning? Let me show you how. If you know to what degree you have to correct in the sagittal plane and in the frontal plane, you can use your plate to generally give you some idea of how to do the correction. By applying the plate securely to the distal fragment, recognizing that to be careful if it's osteopenic bone, because we're going to put a lot of stress on that attachment. And in the sagittal plane, you can have an idea to what degree you are going to need to correct the extension deformity to bring it back to the palmar side. And you can do this to give you some idea using the plate as well. Fixate the distal limb of the plate. Then, once that's done, do the osteotomy. And then as you bring your plate down, it will help correct the frontal and the sagittal plane as such. I'll show you how you can extend the distal fragment as well to gain length through this. So here's a case. There's a drawing. It's a significant deformity. Here's the volar approach. Here's the implant in the frontal and sagittal plane, placed in a way that we believe we can correct a lot of this deformity. And then the osteotomy is done. It can be done with the plate in place if you're careful. You have to go above the dorsal surface to free up the healing periosteum to allow the completion of the osteotomy. So now this is being done, and here it is opened up. The laminar, the elevator is dorsal, that's freeing up the periosteum. And by holding the distal fragment with a plate and the proximal fragment with a pointed reduction clamp, it can be brought back together. In some cases, there's a tendency for radial translation of that distal fragment. So one nice thing to do is put a small lamina spreader between the radius shaft and the ulna and slide over the radius back to the distal fragment to control that radial translation. By putting a screw proximal to the plate, one can use a push-pull technique to then lengthen the osteotomy as such. We see on the X-ray. And in the sagittal plane, we've got a nice correction of the extension deformity, filled with just cancellous bone and the follow-up function. This can be done very nicely without the need for these cortical cancellous grafts. But going from the dorsal surface, it's not always necessary to use big plates. Smaller plates work very well. But the difficulty in some cases is correcting the rotational deformity, and that's what you have to work on. Intra-articular malunions can be done. It's most important to understand the deformity. Having the original fracture films are ideal. Having CT scans are ideal to do this. It will depend on the cartilage. If the cartilage is very damaged, it may not be a good idea. Chronology has always been thought with intra-articular malunions to the earlier the better, which makes sense. But we found that it may not be the case. If you see somebody at a year's time, you still can do something as long as the cartilage hasn't been worn out. And of course, the soft tissue conditions. Here, CT scans and maybe 3D reconstructions will be very helpful. And with situations where you're worried about an inter-articular arthrosis or ligament problem, arthroscopy may be good. I think the contraindications are pretty obvious when you're looking at contemplating doing these procedures, so I won't go through these. Simple intra-articular disruptions, if you're going to start doing this, are probably better. Probably better do it sooner. And a cooperative patient is important because it may take longer to rehabilitate than a regular fracture, and they may think that. Where you do have radiocarpal arthrosis, limited fusion may be better. So let's look at that. And here's a case looking at a very complex deformity. This is from the studies done early on with the 3D computer planning. And you see the deformity. It will give you an idea of the plane of the deformities, give you an idea of where to do the osteotomy. And then it's almost reconstructing or recreating the original fracture, and then putting your implant in place, and a nice reconstruction. That looks good, but it's a lot more complicated than that. Paco de Pinel in Spain has been very enthusiastic and very technically gifted in doing some of these totally arthroscopically. He's developed small elevators and osteotomes to be able to do this. And this was done in this particular patient that he lent me. As mentioned, sometimes you may have a combined malunion. This is a general surgeon I saw many years ago with an intra and extra-articular deformity. And we were able to get CAD-CAM models exactly of the deformity and the uninjured side, and do our preoperative planning in the workshop. And here you can see the extension deformity and, importantly, the rotation. You can see from the normal to the abnormal in the coronal section. And so I emphasize again that rotation is often associated with these deformities. And by doing this preoperatively, it seemed apparent that we could elevate the impacted lunate facet and elevate the extra-articular malunion. And he had to have the plate out later, but he had a very functional wrist for a surgeon. Here's another case that you can reconstruct the original fracture from the deformity, and it's actually a little easier than doing the original fracture. So the osteotomy initially is done in the impacted lunate facet fragments, realigned, and then extra-articularly the osteotomy is made. And in this case, some corticocancellous bone graft was placed. It was a number of years ago, but this is a follow-up on this 11 years later with excellent function. You heard mention bone graft. I won't spend a lot of time with this. There's a lot of different options, but I found once, as Emil mentioned, once we had locking capability for implants, there was no need to have a structural graft. And so we looked at another cohort of 10 patients compared with traditional corticocancellous graft versus cancellous graft. And there was certainly less donor site problems, less pain, and shorter operation. And so I think that in most cases, you don't really need these unless you have unstable fixation. Then that may be helpful. The corticocancellous graft may give you a little additional thing. And you heard about calcium cements, and I've been using those for the last 15 years. Here's a case with a not a very complex malunion. You can see the X-ray, and look at the extension correction and the in two planes, and that's just calcium phosphate, but it hardens like structural bone. So this particular brand will harden within 12 hours, and it will withstand axial load. And we published a series in Journal of Hand Surgery of this. And lastly, distal radial ulnar joint, I don't have to spend much time because it's a whole other topic you're gonna have a webinar on. But realize that many of these are related to the malposition of the radius. Correcting the malposition of the radius, again, particularly rotation, may help a lot of the deformities. And complications, we'll hear now from Marco Rizzo. But I just want to mention one thing. Since we're doing a lot of these through a volar approach, starting to see EPL ruptures. And that's because sometimes when you have a closed fracture that's not operated on, you have a lot of bone growth around the Lister's tubercle. And unless that's taken down, you may realign it, but then that becomes a spike to do that. So let me just show you one case here, like such. Abundant callus or a spike of bone that's not recognized can bring this to play. So just be mindful of that when doing a volar correction to loosen the periosteum and make sure that there's not a abundant callus there. So I'll stop my screen there, and I guess we'll go on to Marco Rizzo.
Well, Jesse, thank you very much. That's just wonderful, as always. There's a couple questions, and Emil answered one, but we could try to rehash it. There's one that may be off topic, directed to you, Jesse. The question was related to what your thoughts were related to close reduction of acute injuries and whether that has an impact on the prognosis, and welcome your sentiments on it. It's not really directly related to our subject tonight, but maybe indirectly.
Well, if I understand the question, is there a place still for close reduction of fractures? Is that?
Yes, and my answer would be yes, but
Sure.
It's directed to you specifically.
Sure, without question.
Uh-huh.
The time that you may need to intercede is if you have an acute median neuropathy that from overcorrection or even associated with the fracture, that you need to do something else about it. But otherwise, no, the volar displaced fractures may be more difficult to do a close reduction or hold it, but otherwise,
I guess the point of the question was, if you're deciding to go, the patient needs already surgery, is it worth doing a close reduction in the emergency room? That's the question.
Oh, well, yes, you should realign the skeleton. Maybe it doesn't have to be perfect, but get the soft tissues out to length. It will make the procedure more easily. And nobody's doing these in the middle of the night, are they? So you're going to be doing it in 3 to 5 days, maybe. Who knows what? So it's far better. It's more comfortable for the patient.
I agree wholeheartedly. I think one of the attendees has their hand up. I didn't know that. If they could just type the question in the Q&A, that might be helpful to Bess. Another question from a hand therapist: is there anything we can instruct the patient to lessen the risk of EPO ruptures, or is it just a risk? And when you usually see EPO ruptures, 3 to 4 months post-op or later, or when do you typically see them?
Well, for acute fractures, more commonly than not, it's for non-displaced fractures or minimally displaced fractures. The reason is tendons rupture 3 ways: attrition, rubbing on a substance, or ischemia is another way. Well, that's what happens in a non-displaced fracture. Is the extensor retinaculum over the 3rd compartment doesn't open, so it gets a hematoma there. So actually, you'll probably see it earlier. You may see it as early as 4 weeks, 6 weeks, or later. What to do? The patient, I feel, I used to tell everybody in a close reduction, if you start having a grating feeling when you're moving your thumb or pain, come back. And it may be, you could consider a cortisone injection, but I don't think it's worthwhile. Just a small release of the retinaculum is probably better. So the therapist can tell the patient, reinforce that.
Thank you, Jesse. Awesome. Nice pearls. Additional question. Are you freeing the dorsal periosteum from I saw from your pictures, you tend to free it from the volar approach. You just come along the sort of the Orbe method of sort of the extensile approach dorsally. How often do you make a separate approach on the dorsal or make a separate incision dorsally?
Well, some colleagues will do that routinely. and so, to release Lister tubercle. But I think if you see an abnormality there, when you're reducing it, you see a bone spur or a very prominent Lister's tubercle, I think you might want to go around it or even make a second approach. The point is, think about it, because it's usually not the screw going through the plate injuring the tendon. It's an attrition that's going back and forth over a rough surface.
Last question for now. Jesse, do you ever not use bone graft?
If you have that so-called hinge situation, yes, you could, but because I've been using calcium phosphate type graft, it's no morbidity to the patient. So the patient feels better and I feel better, makes a better x-ray. When they come back and see the gap there, they say, what's going on? No, and it's no morbidity. So it has worked very well in my hands.
Okay. Emil. Okay. All right, so I'm going to round us out here, share the screen. Thank you for all the questions, everyone. Thank you for your participation. Of course, Emil, thank you so much, as well as Jesse. It's so wonderful to hear your experience and expertise, and thanks for sharing that. I hope you can all see this okay.
Yes.
I'm going to maybe hide myself a little bit here. So, the third case in the series is usually directed towards complications. And thankfully, I have plenty of them to share with you. So this is a 74-year-old female who had multiple comorbidities, diabetes, former smoker, probably still smoking, pulmonary disease, cardiac disease, and obesity. And she presents with this fracture, which to their credit, they tried to do a close reduction and subsequently followed up, which unfortunately happens all too often. They'll see them back a month later or 6 weeks later, and she's lost her reduction with substantial ulnar shortening. They continued with non-operative treatment, and ultimately at 3 months post-fracture, she was left with this. And unfortunately, she complained of a good amount of ulnar-sided wrist pain and pain in general at the wrist. And they ultimately did perform this distraction volar correction osteotomy with iliac crest bone grafting. I guess at this point, I'm going to probably engage Jesse. What do you think of the correction? How would you grade this correction?
Well, it's very hard to do that, but I think it's still radially translated, the distal fragment. You may have some DRUJ problems, and while being overly critical, it's it's a little bit in neutral and not volar tilt. So it may be a little difficult.
I think you highlight some really good points, and I think these are challenging procedures, particularly in patients with poor bone quality. Trying to get them jacked out, and a lot of the pearls that Dr. Jupiter shared were outstanding, but we technically here in this case, and again, this wasn't my case yet, but failed to really get the radial line, the length out, but that wasn't too bad. It was a heroic effort, I have to say. And they did structurally support it with bone graft. I wasn't sure if the DRJ was assessed, but that gap between the radius and ulna is a bit potentially concerning. Emil, you had commented about the ulnar styloid. What's your criteria in a case like this to treat the ulna side? How do you determine when to treat, when not to treat?
That's a good question. Actually, as one of the participants asked that question, how do you address the ulnar, especially in the case where the pain is in the ulnar side? You have an ulnar side non-union. Is it worth taking the styloid out, or is it good to go and fix it? I tend to, if I feel a specific tenderness at the ulnar styloid, I tend to address it, and usually I do a little tension band technique to hold it down, and usually been successful in terms of getting that to heal. And also depends on the instability. If there's instability in addition, then you are worried about TFCC problems, and I may get an MRI ahead of time, or try to look at it at the time of surgery and see if whether that needs to be addressed, and maybe a suture to hold it down.
That's an excellent point, Neil. You don't know until, interestingly, many of these do have preoperative DREJ sort of laxity, if you will, and they tighten up, but sometimes it's the opposite way. They're pretty tight when you start, and when you do the correction, they get loose. And so I've learned to counsel patients that I may have to do something here, whether it be stabilizing or whether it be fixing or shortening or whatever, something that may be necessary to be done at the time of the correction of the radius. And
at that level, just the distal level, that the interosseous ligaments are oblique from radius down to the ulna. So when you lengthen the radius, usually it tightens up, and you increase the stability of the distal ulnar joint.
And Jesse, you wrote a lot about this, the DOB. How do you interpret, or how do you prophesize, if you will, what's going to happen when you correct the radius in these patients? Have you had that experience where sometimes they're not quite as tight as you would thought they'd be?
If you correct your radius, or same in acute fractures, you stabilize it, then what you need to do is reconstruct what happens physiologically, and that's by compressing the radial, the ulnar head into the sigmoid notch and rotating the forearm while the patient's under anesthesia. If it's stable, then it will stay stable. If you feel it popping, then there's a bigger problem. In this case, it may be the ulnar styloid, but otherwise it's sometimes the distal limb of the oblique ligament of the central band, interosseous ligament, distal oblique band. So that's a good way to test in both situations.
Great pearls. So, we talked a little bit about bone grafting, so I won't belabor it. One of the questions that came up was bone grafting really necessary in this case? There are some studies. This is a systemic review, like a Cochrane type review, meta-analysis, looking at 2016, do we bone graft? Do we need to bone graft? Dr. Jipper alluded with the hinge type, and we'll talk a little bit about more hinge versus distraction type corrective osteotomies. And the review actually demonstrated that extra-articular malunited fractures of distal radius treated with volar locking plates does not necessarily require bone graft. I'll be curious, I've heard what Jesse has to say. Emil, do you ever not bone graft?
No, I've used the tricalcium phosphate bone substitute, and as Jesse said, it's such a low morbidity. Take 1 or 2 cc of that packet back there. I don't think you can go wrong with that.
Perfect. Okay. I'm the same way. I never not bone graft something, whether it be allograft or autograft. So another study that I pulled up that sort of highlights a little bit of this, and I'm going to share the study before I share the complication. Okay. So this is a study that was actually out of Emil's group in California, looking at 60 patients who had fixation, and they divided them into two groups. distraction type, which is the type on the left where you just effectively hinge the off of the global cortex without distraction, and then there's the distraction type. This is the hinge type on the left, the distraction type on the right, and you can see most of them were hinge corrective osteotomies, and you can see the demographics of the patients. There was about 4% smokers in the distraction group, 1% in the hinge group. And smokers were 3 and 3 in each group, and diabetes was 4 and 1 in each group, respectively. And they looked at a lot of, it's a really well done article. They looked at a variety of different parameters. They compared the overall radiographic parameters, which improved statistically from pre-osteotomy in both groups, but really didn't have a difference between each other with regard to both groups. Now, you could argue that the distraction type osteotomies are more challenging. They have a more severe deformity to begin with. So we're not really always comparing apples to apples, and you could also conclude similar findings that the overall complication rate is substantial in these patients, and they're going to be higher in the distraction group. And this was what they noticed as well. The top 3 complications were delayed union or non-union, which can be linked to hardware failure, which is the 3rd most common complication. And as Dr. Jupiter alluded to, tendon concerns are a big deal in these patients. Not too far along 4th is neuropathy, so keep that in mind as well. So, of course, with hardware failure or a delayed non-union, you'll see loss of reduction as well. Again, they were higher in the distraction group in terms of complication rates. You can see 15 were in the distraction group, which is a 62.5%, versus 27% in the hinge group. And they didn't seem to be linked necessarily to age or gender. What am I doing? When we look at patient, and this is an interesting finding, but I attribute it largely to the fact that there wasn't enough numbers, and this is what they mentioned in the article. But you would think that the surgeons who had done more of these would have fewer complication rates, but they weren't really able to reach statistical significance in this regard. They also talked about bone grafting, and they said that no conclusions could be made related to the bone graft used, but they pretty firmly, concluded that autograft remains the gold standard, which I think most of us would agree. Although, as you can hear from our panel, many times we're not using autograft, and so this is our patient again. Here she is 3 months post-op, and I would ask, she's holding her alignment. She's had much improvement of her pain. Her ulnar-sided pain is also improved. And I guess I would ask Emil, are you happy right now, or what are you thinking?
I'm happy with the looks of it, but I'm worried about the bone graft. It doesn't look like it's any callus developing there.
It is concerning, isn't it?
Yeah, it looks like a little. I would call it right now delayed union, perhaps.
What do you think, Jesse? Do you ever use bone stimulators in these patients, or is there a role for that?
Well, that's what I mentioned, that the type of material. I'm not mentioning the manufacturer or the name of it, but it is not just like calcium phosphate. It actually has the material properties of structural bone, so that it unites it, but it will withstand load. And having had that material, felt much more comfortable with a gap like this.
Gotcha.
When you're looking at an X-ray like this, see how it's radially translated, and she's osteopenic. It's putting a lot of stress on that gap.
Yeah.
Okay. So one might consider, it's always in hindsight, I would have put a radial plate alongside,
Oh, good thought. Good thought. Yeah.
That would be probably much more supportive than a big gap with a poorly placed bone graft.
Emil and Jesse, I've seen you both use the 2-column plate. That's thought to be structurally stronger plate. Do you lean towards that kind of a plate? I know you also used one of the T plates, Jesse, in your session or your case. Does it matter if you use a T plate versus a 2-column plate, you think, in these cases? Or there just isn't enough science to know?
Well, for me personally, no, it doesn't really matter. Because if it's not healed by the time the material is too much load, it doesn't matter. It's going to fail at its weakest point. It's not going to fail where the 2 columns are. It's going to fail at the gap.
Yeah, you're right. And as and here she is actually here she is at 7 months post-op, and now she's fractured through the gap, as Jesse prophesized. So in this case, do you think, Jesse, if a screw was placed here, do you think it would have held on longer, or probably wouldn't have made a difference?
Well, it might have, but I'll tell you the problem is her osteotomy is done on the volar surface, right? And she has can you go back one? Okay. So she has this bone graft placed, and it probably was a corticocancellous bone graft.
Yeah.
What happens is, and I assume it was placed through a volar approach, what happens is that it's very hard to actually sculpture it so that it's fitting so much perfectly that it's supporting both ends, sides of the osteotomy. And so it almost looks like the cortical side is probably opposite the plate, and the soft tissue part is under the plate. And if it doesn't fit perfectly, it's not bearing a lot of load.
That's a good point. That's an excellent point. As you alluded to very nicely, is that there's this race that's going on between the hardware failing and the bone healing. So, and here we failed. The hardware failed before the bone could heal. Interestingly, what they did, and I'm going to try to move things along as we're sort of past 7, and I don't know if there's additional questions that have been sent out there. But
there are a few questions.
But they opted at this point, which I think was a lesson to be learned. They opted at this point to just hope that it would heal. They felt like we had bony contact here. She's back where she was, and that proved to be a fairly big mistake, because she is now 9 months. Here she is at 9 months post-corrective osteotomy, and this is the time that we ultimately was referred to us. But at this point in time, she developed median nerve symptoms, and subsequently, a couple weeks after that, developed an inability to flex her index finger. So now she has complications related not just to, effectively, we have like the top 3 of the top 4 complications, are all 4 of the top 4 complications from Emil's studies. we have hardware related issues, we have non-union, we have median nerve problems, and now tendon irritation / rupture. And it's much more complicated now. And these are the intraoperative photos. This is, of course, the median nerve here, and the FPL, or I mean FCR here. The soft tissue is over the plate where the fracture is. You can see. I'm sorry, I misspoke. This is the FPL down here. I apologize, not the FCR. So this is the index finger flexor tendon that ultimately I repaired with a an end-side repair to the FDP to the other digits, and ultimately she ended up doing pretty good in that regard. All right, Emil. So talk me through this before I show you how I fixed it. What would you do at this point if you're gonna plate this?
Well, yeah, I would take the plate out, the original plate out, and clear. My feeling, the reason this whole thing fell apart is because sometimes the cortical cancellous, there's not much cancellous in there. It's just solid cortex. So many times you put it in there and it looks like a dead bone, hard cortex. Eventually it fails because it doesn't heal. So I would go for a cancellous bone graft with a very stout, strong plate that would have a ability to hold. Many of the thin, low profile plates is probably not the best for this kind of case. And I'll try to put some traction, get as much length as I can without undue tension on the rest of the soft tissue. And of course, it looks like you did the carpal tunnel release. I would do the carpal tunnel release and take the pressure off the nerve. And
I used 2 incisions because you wanted to use a rolled incision. Would you have just done an extended ulnar approach, you or Jesse? Would you have ignored the old radial incision?
No, I wouldn't, because you already have an incision. I don't know, go and give it like a centimeter or 2 centimeters space. That's probably not the best. I would use the old incision.
Okay. Jesse, would you have done more of an extensive ulnar approach, or would you just done 2 incisions as well?
I'd use the original incisions.
Okay. So what I think is really helpful in these cases is these diameta plates, and there's a variety of different types. There's 3-5 fixation proximally, and you could argue, Marco, you went a little overboard with the length of the plate, and maybe I did, but in addition to structural graft, which I took from iliac crest, which one of the lessons I learned from this panel is that maybe I'm overly, I should probably consider some of the allograft substitutes, and I'll take that to heart. I did do a distal ulnar resection because I was not hoping to get her out to length again. I was going. This bone was quite soft when I got in there, and I was concerned if I jacked her out too much, I was going to create other problems that might lead. One nice thing about her is she still has a fairly well-maintained joint.
Yeah.
So if I could preserve that and shorten the ulna, that would be the way to go. And here she is at 1 month post-op, and here she is at 5 months post-op, and ultimately at 9 months post-op. So thankfully she went on to heal. She's still quite limited overall with regard to her mobility, but she's functional and she had good pronosupination, and so we sort of got out of that mess. Any comments about that, Jesse, Emil?
No, you can't argue with success.
One thing is, you were fortunate that her soft tissue was very compliant.
You're right.
When seeing some of the deformities like that, we call them radial club hand or post-traumatic club hand. And sometimes I put a distractor on intra-op to slowly distract some of the soft tissues if there's more adhesions and less compliant soft tissue.
Thanks for the advice, Jesse. Yeah, I was going to ask about whether X fixes or distraction fixers would be helpful and how often you use them.
In your case, since you took the ulnar head off, you're not obligated to go all the way up to where it was before. So that's an advantage. So you can be shorter and not put the soft tissue in jeopardy.
Right.
I just have a few take-home points. You know, these are challenging problems, whether they be, I think that, you know, I didn't touch upon a complication of intra-articular ones, but one of the things that I thought was among the many pearls of Jesse's talk was those radioscapholunion fusions. I think they work pretty well in some of those where the cartilage is sort of pretty significantly affected, and many of them can have pretty functional outcomes. Complications related to fixing these is not uncommon. You know, there was this sense of there's nothing to these procedures for a while, and this most recent article sort of highlighted that these aren't as easy as the literature is describing. These are challenging procedures, and a lot of the 3D technology that Jesse highlighted, it will be really helpful for some of the more significant deformities to try to plan appropriately. And be prepared for plan A and B, as we talked about. I think with particularly you know, what to do with the ulnar side of the wrist. What do you do with the DRUJ? What if you can't get her jacked out? What if you start to cut through the bone? What are you going to do? I think about those potentialities and speak with the patient ahead of time about it, so that they're not surprised and you're not in a situation where you're doing something you really hadn't discussed initially. All right, I'm going to stop sharing here, and thank you all for your attention.
There's one common theme on some of the questions that is being brought up is what do you do with the post-operatively in terms of rehab? How long do you mobilize after the surgery, and when do you start range of motion exercise? Any of you have any comment?
Jesse, I'll let you go ahead. And
I obviously depends on a lot of factors. If your soft tissue is compliant and you have a nice closure and you're not so worried about swelling or you've distracted too much and you feel you have adequate fixation support, I would make a post-op soft dressing and a volar splint for 2 weeks, and then a removable orthoplast splint that allows some more hygiene and minimal activities, and then depending upon the x-ray about functional loading. But all the while they should be working with hand rehab. What you don't want to do is forget about the fingers and the hand. So be careful about too much swelling, and work on mobilization of the fingers and work on forearm rotation.
Amen. One of the questions was my most distal screw on my last fixation. Appears to be in the joint. You know, if you get a lateral tilt view, you'll be able to see that you're fine. You know, that 30-degree tilt view, it can sometimes give you this impression that you're in the joint. But I can assure you that that screw is fine, and I can try to pull up an x-ray that shows the tilt view, but it's deceiving when you get a straight lateral without the tilt view. But to get the tilt view and do that intraoperatively, that's very important, because you want to know then if you're in the joint space.
It's not so easy if you have screws in the radial styloid to the ulnar facet. You can do the skyline view, help a little bit, but not so much for the radiocarpal joint. And on the horizon is intra-op 3D fluoroscopy, which will give you a 3D scan. We have a series, an international study that we've done that, and they've been using it quite a bit. And I'll allude you to a study out of Japan where they looked at post-op CTs of their cases. And many people don't get post-op CTs of the cases, but found between 40% of cases had a screw either penetrating the dorsal cortex or in the joint. Then they started using 3D intra-op CT in a smaller number, but they didn't have that problem anymore. So it's a good question they asked you, because it happens more than you think.
Yeah. Well, you know, it's it's almost like robotic joint replacements. Having this 3D information can
Yeah.
keep you honest, and you know, we've all seen those complications where screws in a joint or penetrates the dorsal cortex. Okay.
I guess there's one more question about when you do an osteotomy and you have a space. When do you allow weight bearing on the wrist?
For me, it's got to be healed.
Yeah, I was going to say 3 months is usually where I start to consider it. But the X-ray gives you the guidance. You know, the X-ray helps you, and of course the clinical exam. But the X-ray is critical. You can always get a CT as well at that point if you're concerned or want to get them. But
And one other question about what is the indication for distal ulnar resection in the setting of malunion, whether you do that instead of the corrective osteotomy or combined. It's an open question.
It's very difficult if you've got a rotational or length problem with your with your malunion, because stability of the distal radial ulnar joint comes from contact pressure of the ulnar head to the sigmoid notch. So if your sigmoid notch is not in the right plane, you may not have a good distal radial ulnar joint function, even if you shorten it. And years ago, there was a nice study looking at the axis of the sigmoid notch in malunions, and how that some of those cases, the sigmoid notch the axis is way off. So you really have to do a distal radius osteotomy. Excuse me.
yeah, I think Jesse touched upon it. Getting the radius right is the key. You know, there's other factors associated. You know, of course, the length is always an issue. How much positive variance can you accept after you do the correction? It's always good to get contralateral films to see how God made them, so you can get an idea on how to achieve where you want to be. But, you know, the younger patients, you know, Doug Hanel said this eloquently years ago, and I've always thought of it. Once you take off that ulnar head, there's about 8% of patients who go on to have a miserable experience. So I wouldn't willy-nilly take out the ulnar head, particularly in a younger patient, you know. And that's something obviously you need to discuss ahead of time. Sort of, what do we do if we can't get the radius where we want it? Should we shorten? Make sure the radius is right, though. And the patient that I had, the 75-year-old, it was fairly straightforward that we would remove the ulnar head rather than do something more heroic to try to keep it individualized. Sort of what I'm saying.
Well, it looks like we already 3 minutes past our allotted time. I want to thank you, Dr. Jupiter, for your great presentation and participation, and Marco
Thank you,
for
Jesse.
your great cases and contribution, and all our audience that have been hanging out and great questions that they submitted. And I appreciate and look forward to the participation in the next webinars. Thank you very much. Bye-bye.